But it is which requires that kind of environment to start it. And many of our alumni, not only from this department,
Yes.
many departments of this institute,
Yes.
they have made the need of super specialty manpower in almost all the corporate hospitals. And not only that, they also laid the institute and take the name of the institute in different parts of the country to create departments.
Yes.
Like, for example, they went from here at endocrine surgeon, they have created a department of endocrine surgery in other institutes. So that is the kind of play that we have played. So that's why I say it's unique in the concept.
Yes.
The other thing unique in Rakesh is here. Welcome, Rakesh. So it is he's the director of GPMO Pondicherry. Some of our faculties are very innovative.
Yes.
Innovative in the sense they think something beyond their specialties.
Yes.
They are kind of thinkers,
Yes.
visualizers,
Yes.
whatever can you say that.
Yes.
So, for example, our traditional doctors cannot think of IT. And we thought of IT when nobody ever thought of IT.
Yes.
I'm really surprised, Rakesh is one of this founder of the IT movement in this institute.
Yes.
We are the first to develop hospital information system
Yes.
in-house
Yes.
with the help of the Center for Development and Advanced Computing
Yes.
and our own hospital information system,
Yes.
which nobody had that time.
Yes.
And today, hospital information system, that is medical record,
Yes.
is so much important for research.
Yes.
So much important for, we talk of the data analytics, precision medicine, artificial intelligence, and so many things.
Yes.
Without a proper medical record, we can't have anything. So we are one of those torchbearers. Second thing is telemedicine
Yes.
and informatics in healthcare.
Yes.
I think we are the first in the country to bring this concept. The building that we are sitting now,
Yes.
the School of Telemedicine and Biomedical Informatics,
Yes.
is the only of its kind. Even in the whole of UK, you will not find such kind of institute where there is a 4-level building devoted only to the health IT. Today we are talking about AI. We thought of neural network 10 years ago, or maybe 50 years ago when you started this building setting up. There was a lot of space for created that.
Yes.
Rakesh took initiative with Amita and others to create a bioinformatics lab. We got grant. So we created infrastructure where many diverse disciplines will come forward. Today, molecular medicine, they cannot survive without bioinformatics.
Yes.
Today, we talk of patient safety. We cannot do this without IT. Talk of open any journal of patient safety, you will find there is heavily loaded with artificial intelligence.
Yes.
Be it a critical care point of care,
Yes.
you are talking of course, I'm not going to the downside of those things.
Sure.
So, I just brought those kind of information to all of you
Yes.
to say that we are very unique.
Yes.
And last but not least, to tell you one thing,
Yes.
the theme that we are conducting workshop here,
Yes.
that we have been thinking many years. I think Rakesh Pandey is not here, but you are one of those partners also, and Amita is also, and all the people are part of this thing. Many other faculty must be part of this thing. We have something called 01, 02 courses. It's nothing but soft skill. That we have been doing for many years. Again, it's unique for this institute, but many others do not have this. We have also a module on patient communication. We had, but what is going to happen after your visit here? Definitely, our effort will take both. One thing I like to say, I mean, these cannot be sporadic events. This is my suggestion again at the end of my talk. The suggestion is, you went to Chandigarh, you went to some other place, you took another place, you just did the event after that, or quiet. And there are enough of research material available, and published in good journals like Lancet, that we spend a couple of seconds with the patient, especially in developing world, because they're loaded with patients. By the time patients start complaining fever without knowing other associated symptoms, I write prescription. You go to the primary health center. There is, by the time a patient complaint is over, prescription is ready. So this is well prevalent, and this is more so in developing world. See the heavy loaded. You go to the UK in NHS. Your patients are diverted to GP. We have a well managed system. My nephew in Canada could not get an appointment from a rheumatologist before 6 months. Here, instead of going to primary care, you go straight to the super specialty. That is the problem. Because they don't get good communication from the patient. A cough and cold. Why should I go to super specialty hospital? Because they are not convinced. Only thing is communication. If you really communicate properly, say to the patient, and in your clinics, I had little experience of UK staying for 6 months, you get hardly 5 or 6 patient appointment. In consultants is only 5 patients. Correct me if I'm wrong. Only 5 patients. That too, on recommendation of GP. Unless GP takes an appointment, the patient cannot come to consult. So you have got 5 patients, Why not I communicate? You have several cadres of paramedical workers to talk to the patient. You have nurses, you have clinical practitioners, you have social workers. So many people are there packed. For breast cancer patient, before reaching consultant, already 5 people have spoken to her. Here, it's not like that. So then again, this topic is very, very relevant. At least for the resident, I request you, please spend some time. I know you are very hard pressed in the OPD. I was doing all these things, but can you make some time? So I always said, if you want to deliver something good, go to the most busiest person. It is true in all spheres of life. One bureaucrat, senior bureaucrat showed me once that if you want to get it done, these are fundamental principles. Give it to most busiest person. So they cannot remove a inefficient work of government service, but they can make them sit idle. They get work done from this. So here I request all the residents, please make an example, set an example, spend some time with the patients and relatives. Very important, not only patients. Make counseling room in each and every ward. If you have some experience, you come down my ward. There is a counseling room, there is a video screen, there is a video recorder, recorded systems for breast cancer, thyroid surgery, shown in the tablet, shown in the television. We talk to each and every patient. That has tremendously brought down the load of analgesics. Patients are very happy to go home the next day. Unless you talk to them before, discharge tomorrow? No, something will happen. They will create artificial symptoms in virtual world. So if you have shown them, no, it hardly matters. This is thyroid. I am removing only half of this thing. It's a small operation. It will just be finished. And evening by evening you take your oral fluids. And next day patient will go. We have brought out an article in short stay thyroid surgery 20 years ago, published in National Journal of Medical Journal. That patient discharged in 24 hours. Is it not affecting our health system? You're cutting down the price and everything. So that's exactly I'm telling you. Your power of communication, your power of skill of communication. There is a skill attached to that. It's not that that is going to, you're speaking about all those things I know very well. There are, with the advent of this technology nowadays, especially the IT, there's no question of thinking anything. It is all in the front of you. Get a simulated environment. This is the theater, you are going to hold it like that, this is the thing. Everything is person explained. They know that what exactly you are going to do with me. What is this operation? What is the implication of the operation? Even now, there are patient simulations. You can simulate a patient of breast cancer and explain the patient and relatives, starting from diagnosis, how I'll diagnose, till the patient gets chemotherapy, radiotherapy, everything explained in the virtual world. I think I'm sure we'll talk all about all these things. This is just my interest in patient communication using IT. That's why I spoke a bit more on that. So we look forward to be more enlightened by your talk. Thank you again for visiting us. But do think about sporadic events are not going to work. That's my suggestion. We have a beautiful network connecting medical colleges of the country. If you wish to continue your effort, from Birmingham we can link you. Today we have been linked to so many medical colleges. Your talk is linked. We can link you to Birmingham and you can reach everywhere as a follow-up.
Thank you very much. Yeah.
Good morning. Warm welcome to you. As we told that how important the topic of patient communication in general. And we realize that particularly in rheumatology it deals with chronic disease and the patients take medicines, advice almost indefinitely. Patient counsel becomes a very challenging issue. We realize that every day because patients who have come regularly to our clinic for the last 10 years come up with the same question that she has asked in the very first visit. And the question for rheumatoid arthritis, when are you going to stop your medicine? And do I eat curd? And can I stop this medicine and try? The basic thing is there is a huge gap between what we intend to say or what we intend to advise, what we intend that the patient should undergo, and what the patient thinks that he probably reading as much as we read her mind in the consultation. And he or she would very much like the doctor who says, this is the stop of your steroid, this is your stop of the treatment, and that doctor becomes the darling for that moment of time. So somewhere, the complexity of the disease, as we understand, is actually never perceived by the patient. And it doesn't matter really whether the patient is educated, uneducated, what the patient wants. Can she be free of medicine and the doctor who is sitting right next door, opposite the chair? That is the very sole name for which the patient is coming. When is this entire ordeal is going to stop? It doesn't happen, but our job becomes very difficult. We realize sometimes patients can have very severe complications, and they were not expecting that, and because of our treatment, they go line up in complications. All these is, I don't know how that can be communicated. And you have to really go down at the patient level of understanding, and once she feels that you are talking almost the same, in the same tone, you can't of course say, talk in the same language, then there is a possibility that the war is won. Description is nothing. So, Kanta has been here before, and to introduce to an audience like this, we have nurses from other departments and healthcare provider. I would read out something which is very impressive for someone like Kanta, who has almost dedicated in this aspect, particularly the behavior of the patient and their psychological reaction to the disease, and particularly chronic disease. She is currently the program director at the Institute of Clinical Science, University of Birmingham, UK, for advanced practice in healthcare. She held a post at the University of Manchester as a lecturer until 2017. She completed her NIHR awarded. What is NIHR?
It's National Institute of Health and Research.
Prestigious. Clinical doctoral PhD at the University of Birmingham in 2015. Whenever University of Birmingham is mentioned, I remember our dear guide, friend, collaborator, Paul Bacon, who also Saroj knows and who everyone knows, who is a good friend of him, who visited our institute, and actually, probably as I understand from Amita, it is all who probably linked Amita with Thiru.
Yes.
That is, as I understand. The PhD work focused on the issues related to the medication adherence. This is very important, and influence of ethnicity in patients with rheumatoid arthritis. Her research uses psychological theory to develop effective behavior change intervention and to understand psychological reaction to health and illness. Her areas of research include behavioral medicine and impact of ethnicity on musculoskeletal disease. I wish some of our PhD students actually delve into this. I mean, this is so important. She has published extensively in these areas and has developed a national reputation for the work in ethnicity and rheumatology. And now perhaps international recognition, if you are moving beyond UK. Dr. Kumar has won 5 national awards to date for her outstanding work. The impact of her research on patient care is bringing together all major stakeholders, including British Society of Rheumatology, patient charities, industry and the NHS. With a continued commitment to improve care of patients with rheumatoid arthritis, she has developed a timely innovation with National Rheumatoid Arthritis Society and the wider rheumatology team across the UK and abroad to make a greater impact. the way we practice rheumatology here is easily from the patient perspective is something like 10 to 15 years behind what is done in UK. At least to reach the patient, we are nowhere near. We have got a lot of work to do. Is that enough of an introduction? Welcome, Rakesh.
Just a few.
So, you have.
Does collar mic go on? Otherwise, we have to. Or you can. Or you can speak from there. Even will be heard, I think. You speak louder enough? Not loud enough. It's hand mic over.
So actually, if I stood here, can
Yeah,
everybody
yeah.
start and this here? Can you hear? Can, no? Okay. I'll go. Can you hear me now? Yeah. Is that okay?
Rajita, can you hear at the back?
Yes.
You can't hear? You can move here. You can't hear, can come in front.
Thank you. So it's a real privilege to be here back again. I came last year in September 2018 and I met this wonderful, very ambitious team and it really touched my heart, and it's because of these two people sitting at the end here that I'm appearing back here again. So I thank them for the inspiration. I also thank the Dean for his speech, and I am glad to hear in that speech that there is a lot of innovation, and I am so glad to hear that the innovation and new ideas are impacting not only on our science and how medicine is now interacting with our patients, but I'm also really delighted to hear the fact that the room for further new innovation is welcomed. So thank you for that. I would also like to just touch upon the fact that, yes, in the UK, we do have our challenges. And I guess the challenges are probably different, and every country has its own challenges. And I'm not going to stand here and tell you that we are perfect. We are not. We are not perfect. But our challenges are slightly different. But more importantly, the challenges that you are facing, and I have been here since last Sunday, the challenges that you are facing, and as Professor Misra has just highlighted, perhaps there are some gaps that we have filled in already in the UK, and we are perhaps leading in some ways about the science and the technology and about evaluation and clinical outcomes and measuring those clinical outcomes. And this is what I would like to bring to you, and this is what I bought last year, and this is why Professor Misra and Professor Agrawal actually felt that there was a gap in the way we communicate our science with our patients, and that's the reason why I'm here. So thank you very much for your speech, Mr. Dean. That was really, really enlightening. So what I'd like to just start off saying that I feel as if I have been on a pilgrimage since last year. And this pilgrimage has started right from here. That's why I'd like to credit that. And since last Sunday, we have visited many institutions, and not because we want to, of course we want to highlight our University of Birmingham profile, but actually what our aim is just to add value to the workforce and add value to the way we can help, add value the way we can advance your clinical practices. That's my main aim. And above all is to understand what are your challenges here. And since last year, and also this week, has really consolidated that the challenges that you're facing actually are across, doesn't matter if it's a private or secondary sector, and the challenges are lack of time, limited time with the patient, and that sheer amount of population that you're seeing is really, really a key part to your practice. And because of that pressure, and perhaps because of the lack of support from the health ministry, I think you guys are doing an absolutely fantastic job. And I said this when I stood here last year in the rheumatology department, but I'm saying it again, that I salute you guys for doing a fantastic job, and that's from the bottom of my heart. It really is. So with that in mind, what I thought today was just to kind of give you some insights into what are we talking about when we say that we want to improve our consultation. There are lots of models that we can use in our consultation. Of course, we start off with that few minutes, and yesterday I was at the SGT University, and one of the very wise doctors over there said that until you put your hand on the pulse and look the patient in the eye and say the name of the patient and address them by their name, you've lost the connection. If you don't do that, you've lost the connection. Would you agree with that? Huh? Yeah? So Professor Mishra has already said about using the tone, using the language, and really kind of, building those human connections are very important, and our prescriptions comes later on. Our prescription comes later on, and this is what Professor Mishra was saying last year, that I am just a prescriber and anybody can do that. Isn't that right? There's lots of health professionals now taking up courses to prescribe. Anybody can do that. But to connect with the patient right at the start is an art, and it does require skill. And I must say, as I talk for the next hour, that skill develops with experience, and it also develops in studying further. And that's God's honest truth. It does. Our experience adds value in the way we handle situations, but the way we conceptualize our consultation comes with extra knowledge and advancing that our healthcare consultation. So with that in mind, am I pointing at the... Pointing here?
Yes.
Oh, that's right, that's right. Yeah. Okay, so what I'll do is then, I'll just take you through then, what are we going to cover today? And this is just giving time commitment. I would love to stay here for another week and then give you all the coverage for this. But within this 1 hour, this is what we'll cover. We'll look at the hinders of optimizing clinical outcome. We'll look at some behavioral models that help us to engage patients better. And I'll suggest some tips that could be used. And those of you who will really put your hand on the pulse and connect with these slides will actually take away key messages. And then I'll give you some very simple examples from our rheumatology, from our clinics. And I totally agree with Mr. Dean, who pointed out earlier that in our country, GPs, and it doesn't matter who, I think it is about connection. And those ones who are really connected will obtain better outcomes. And those are the ones who are sitting in outstanding institutions. And I just wanted to highlight that this is why I'm here. University of Birmingham and our rheumatology is the world leading rheumatology. It's because we value that importantly. So I'm hoping that you'll take some key messages from here. So what I always kind of say is that this window opportunity, where is my pointer?
Pointer doesn't work here because this is a screen, LED screen.
You need to.
Chalo, never mind. So the
Not working.
LED screen pointer.
Brighter blue light. Inside the mouse point.
Mouse.
LED screen होने का.
Yeah.
Only Screen is too bright.
This is all technology.
It's working very slowly.
No,
It's
it
working
won't.
very slowly. But never mind, never mind. I'll just ask you to. Anyway, so here's a slide. Just a slide. But just look at the journey that is on there. This is a journey of patients as well as you. So we set off in a journey every single time we see a new patient in our clinics. Every single time a new referral comes in, and this is how it is. And I just wanted to highlight that this is an opportunity. So every patient who walks in is an opportunity at this stage. Yes, challenges, we'll talk about those later on. Here, what happens is that when a patient or person realizes there's a problem, they come to your doorstep. And then, in some countries, like we're pretty fortunate, I know there are waiting times, but that's not the case in every single speciality. But we have gatekeepers as GPs, which is the general practitioners. They tend to refer patients into the system, and here you have got that direct patient will self-refer, or maybe an orthopedic will refer. The patient ends up on your doorstep. We then diagnose the patient, we then start the patient on treatment, and then the patients in this country are perhaps carried on being looked after by yourselves, and this is perhaps the sheer amount of burden. There isn't any primary care setting that can actually share that burden with you. The opportunity is in that this is a golden platform for you to engage, get the patient's attention, engage with them, and treat them, and also teach them how to self-care. And that's really, really important, isn't it? Because you're only going to spend 5 minutes with them. However, they need to learn how to live with the condition for many, 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 many years ahead. But that takes time for the patient to understand that it will be many, many years. Start again.
What?
Go. Just do the next one. So let's just look at the challenges as well. Challenges which are perhaps out of our control. But how do we conceptualize these challenges, and how do we make the most out of that consultation? These challenges are very wide. These challenges are very much in society and embedded within society. So access to health services, and I understand working with Amita and working with Avinash as well, Dr. Avinash Jain, who's moved on to Jaipur, I've learned actually this is accessible. The service is accessible for some population, but there is a massive shortage, isn't there? There's a massive shortage in the access to the right services, and that really does delay the patient. Sorry?
I guess this will happen. Don't worry.
Is that okay?
Yeah. That will be easier for you to do.
Do you want to take the please? So, yeah, so there are services that are very accessible, but I've learned working with a research project, actually, there are some services that are not available to the patients in time. The engagement is a massive problem, and I've already started with Professor Mistra's and Professor Agarwal's clinics to learn the level of engagement. Then the ability to connect with us. And that connection really depends on in your ability to convince the patient that now there needs to be a change. And if we're just doing it verbally, we have lots of knowledge in our minds, because that's what our undergraduate and postgraduate knowledge is giving us and our courses are giving us. But if we are not able to communicate that in a meaningful way with the patient, then really our science is really fruitless. Then the patient experience and the health outcomes. And I know that particularly in rheumatology, they're very keen to measure the outcomes. And I don't know about the other specialities at Sanjay Gandhi, but if we are not measuring the experience and we're not measuring the outcomes, then you will never know how well you are really doing and how well you're really progressing. And that really goes hand in hand with your approach with the patient, and it's really, really important. The socioeconomic factors, well, these are, as I said from the outside, they're very much out of our control. But how do we make the best out of the opportunity with the 10 minutes that we have been given? So the opportunity that we were talking about earlier, this is the way it becomes very diluted and challenging. Challenging because there becomes a very a quick response from the patient in disconnect. So if you're not going to have a right approach with the patient, the disconnect will be instant. And that is a problem. This is where you all become conveyor belts. You'll be seeing the patient over again and again, again and again, flares, doesn't matter what it is, which chronic condition we're looking at. That mechanism of follow-up becomes a real frustration because of this disengagement. Adherence and resources and self-management, these are all the important concepts to us as a clinician. But if that approach is not there in a conceptualized way, then it really is a massive a challenge. It's a massive challenge on top of what you already are experiencing in this country in terms of your societal pressure. So I like the journeys, and I always present these pictures because although the patient pitches up to us with their problem, but actually it's our duty and also our opportunity to really walk with the person with this journey. Now, I've put the weighing scales there. That's if you are in balance with that communication in your clinic, then you'll be winning that situation. However, if one of you are out, if the weighing scales are up or down, then there'll always be a mismatch of that communication, and it will never kind of give you that outcome that you truly desire. So, Professor Misra has just talked about training, and Mr. Lee was talking about training, and how fortunate the prestige of the undergrads and postgraduate, and this is postgraduate university, training you up further. Now, within that, and I am learning, working again with Professor Agarwal, is that the skills, these core skills, are lacking in the undergraduate training, and they're also lacking in every other probably university across the world. It trains us up, it gives us good knowledge of anatomy, physiology, pharmacology, immunology, other things. And yes, there are soft skills about communication, but does it really prepare us that with the core training that one would like, it really to deal with the patient with chronic long-term condition. And we really underestimate that, really, don't we, with people with chronic long-term conditions. I think because we get into this conveyor belt scenario in our heads, and then we forget actually this is a long-term thing for the patient. Yeah? So it becomes really important. So what do we actually know about communicating with our patients on this day-to-day and on this again and again follow-up? I would say not much, and that goes for me. Hence why I wanted to kind of step out of the discipline and learn something else.
And learning that something else has actually made me realize that actually there's a lot more to our consultations, a lot more that other disciplines like health psychology can actually deliver and engage with us as clinicians, where we can actually really have that fruitful outcome with the patients. So when we're talking about a very typical successful consultation or clinical outcomes, what do we really focus on? We focus on the decisions, yeah? We really focus on the patient involvement, and it is really important. It doesn't matter what JAK inhibitor or what biologics or what advanced therapies you're going to give to the patient, but if the person does not engage, then everything is fruitless. Our science becomes fruitless. The self-management, as I already said, self-management is very important. You don't need to learn how to live with that condition, they need to learn how to accept that. And that is a key, and that is an art on your part as well as on the patient to bring them from A to B. Reviewing the progress. So last time when I was here, I sat in with Professor Agrawal's clinic. She has a laptop of her own that she has in front of her, and she's recording everything, which is absolutely beautiful. Yeah? We are fortunate in the UK that we have other people while the patient is waiting in the outpatient department who can collect data on our behalf. And we acknowledge, and I learned that this last September, you don't have that fortunate having people, research fellows or research assistants handing outside to collect that data. But she's not losing that opportunity, and I just wanted to bring Professor Agrawal's enthusiasm here, because she's so keen in monitoring the outcomes of her lupus patients. And she says, so if nobody's going to give me a person to collect the data, I'm going to do it myself. Huh? This is not to big up Professor Agrawal here, but this is to say, actually, it can be done. Under the pressures that you're working, it can be done. So progression and monitoring progression is very, very important. That comes in with the beauty of the art of communication. That brings me onto this slide nicely. So how many, probably the seniors, Professor Misra is probably on this note, aren't you, Professor? This is where Professor Misra might be. Do you think? Are you at this stage now? Shouting at the patient yet? No. He says, no. Right? And what happens is that when we are dealing with different patients and different characteristics, different people, because we are all different. In this room, we are all different. Some of us will be having a curiosity to engage more, learn more, and some of us will say, just tell me what it is and I'll deal with it. Yeah? Would you agree with that? Jaldi batao, kya lecture laaya hai, ek ghanta mujhe batane ke liye. Some of us will say, take your time, just explain because I want to understand. And that's the reality of our patients. They're just patients because we label them, but they are people. But dealing with people, learning people's characteristics in those few 5 minutes that you have, it is an art and will come only with acquiring extra knowledge. So let's just look at this model that you have in front of you. So the sender is you, and you started off like some of the residents sitting here, you're nice and fresh and you're young and you're going out there with lots of energy and you're going to engage. Na? ऐसे ही होता है, वैसे होता है. 5 साल के बाद आपको क्यों नहीं समझ लगे कि मैं क्या कह रहा हूँ आपको? ये करो, वो करो, वो करो. 10 years later, you're gonna. I've got some nods on the back there, and some smiles. Na? 10 years later, you become something else. 20 years later, you become something else. Because you are now part of the system, and part of the system means sometimes it does happen, and this is what's happening, Mr. Dean, as you pointed out earlier, that GPs or the NHS system, we become part of that system. And when we become part of that system, we forget how innovative we need to be. We forget what are we really here to do. And it is only, I would say, a handful of people who really engage with this sender and how effective, innovative the sender needs to be. Calm, collective, skillful, knowledgeable, and innovative in their idea. Then what happens is that the message that you send out will hopefully reach to the person effectively. However, if those skills are lacking, if that knowledge is lacking, then you'll get a receiver which is asleep on the other end. And if there is sleep on the other end, your feedback into your clinical outcomes will be negative. Would you agree with that? Agree करते हैं? हाँ, ठीक है ना? कोई सो तो नहीं गया? ठीक है ना? Okay. So this is where, and then on top of that cycle, so it becomes like a vicious cycle. And then on top of these, when you step out of sonography, you've got these factors playing. And you're thinking, I'm tired. Then you've got the heat on top in this country, 45 degrees. Not to mention. So it becomes a very exhausting system. But every single time we have to innovate ourselves to say, actually, what am I really doing here? Where am I going? A to B. And I guess in rheumatology, I haven't been to other departments, and please excuse me if you are from other departments and you also are equally innovative as you are in rheumatology. But in rheumatology, I actually learned that despite all these things that are going outside, there is a way of keeping that innovation alive, and this is why we have Rakesh here, who is now innovating another hospital in another part of India. So the change is very important. Change happened last year when Professor Misra and Professor Agarwal sat there and they heard me just talking about my research, because that's what I came to engage with. I came to present my research profile and how I can engage with Professor Agarwal in India. And out of that, they said, some things that you just presented are really, really useful to us. And they're useful to us in the sense that actually we all recognize the gap in here. And this is where they wanted to bring in some change, and they're thinking about the change, so that when they are producing you as consultants, future consultants, that actually you're acquiring good skills, so that you can make that impact within your own clinical practice. It's not just consultants who are sitting here, there are also nurses who are sitting here. And nurses, I'm learning in this country, it's a strong progress in building you as a workforce equally to add value, because you also hold lots of power, and the skills that you could add are absolutely immense. And your seniors sitting here are realizing that, but it is a small progress. However, there is a motivation towards the change. So once that realization has come, and I'm very, very delighted to learn that that change has come, because that's why we have been invited to 7 institutions across India, because a handful of people are thinking, "Arey, kuch to change hona chahiye." Okay? You might not rock the government, but you are rocking within your own departments. And again, I salute that ambition. So, when we're looking at consultation and engagement, what are we really focusing on, right? We're focusing on, at the top, it says, good fit. We'll talk about the other 2, common sense model and necessity in a minute, but let's just talk about good fit. What do we mean when we mean good fit? Good fit is when a person comes along, a patient comes along. Who can I use as an example? PGI. आपकी स्पेशलिटी क्या है? हाँ. Gynecologist. Right. Okay. It's all right. Right. कोई exam नहीं होगा. So let's take that as an example. So you've got a woman with lots of problems, and there might be some minor problems which you could correct very quickly. If the quickness, as Professor Misra said, is that we can't make the disease go away because we haven't got the science behind that at the moment, we are moving towards, in each discipline and each speciality, we are really working hard across the world so that we can crack the science and we can learn more from science so that we can give that remission for patients longer. At the moment, we can't switch everything off. Because you tap to nahi hai na, फिर on कर दिया, फिर off कर दिया. So let's take the woman in your practice. Sorry, what's your name?
Dr. Navneet.
Navneet, Dr. Navneet. So let's take Dr. Navneet's example. Gynecologist is a woman who pitches up with a
If you want a chronic disease, then it can be endometriosis.
Exactly. So let's take the minor problem that you will be able to correct. So the person comes in and Dr. Navneet will say, actually, this is इसकी कोई फिक्र करने की बात नहीं है, ये एंटीबायोटिक्स ले लिए, ये ठीक हो जाएगा, वो लिस्ट दिया जाएगा. The person finds a good fit. Yeah, it's a good fit for them, and that's what a person always is looking for the good fit. However, the problem becomes, as you say, when it becomes very chronic and when it becomes lifelong, nobody wants it. None of us want it. But because we are health professionals, we have the ability to rationalize. We have the ability to our own knowledge, and we can conceptualize and work with our clinician and say, right, okay, this I know how you're going to move me from A to B, because you've got the knowledge, you've studied the textbooks, but these people haven't, who you're seeing every day. And here then what happens is you've got this interpretation which they learn from outside, from social messages and through their own symptoms, and then they'll develop a model. Believe it or not, there is a model. As in Indians, we are very much pure focused, and we are. And maybe we should be focused because one day we might get it in every speciality. So it's not bad, but we have to say to them and conceptualize it that there isn't a cure at the moment. I am here to help you to control. But we are also here to gather outcomes. So let's take Professor Amita Agarwal at the moment, who is really focused on lupus and JII. She wants outcomes because she wants to tell the world, she wants to publish, she wants to tell the world, this is what's going on in India. She wants to publish in higher impact journals. How can she publish in higher impact journals? Tell me. How can she?
Doing research.
Through research, but also what else?
Recording the details.
Simple baat hai na? Simple baat hai. Recording the outcomes. Agar aapke paas, yes, then we think about an idea, then we put a methodology, then we get funding and we plan. We cook up a recipe, not for that, collecting the research, but the outcome is very, very important. But believe it or not, if you can't understand the perception where the patient is coming from, you will not publish in a high impact journal. It doesn't matter if it's hardcore science. Yes, if you're looking at natural history, natural pathology, natural immunology, that requires just a blood test, fine. But if you want to move any further than that, you need patient engagement. Let's just look at this very briefly then, when we're talking about engagement. So if I just ask you to focus on the lighter green, where it says identity, label, symptoms, just look at that box for me, because this pointer isn't.
This pointer to the just use the mouse.
That's my. Just mouse is a little bit slow as well.
It'll go. Mouse will be fine.
So let's look at that. So what happens here is that the patient starts off with their own identifying what could be the cause. They're not going to say, who is this swelling and very durable, looks like an autoimmune condition. That won't happen. That won't happen. So there is their own conception and their own weighing up consequences, their own cause, their own control, and their own timelines that they give to this. So they pitch up to you, and then you're giving these messages right at the beginning, if you look at there, the messages. And I showed you the diagram earlier, whether you are engaging or whether you're just shouting that message across. And then it's the perception. Do you really break that through? And that breaking through comes with your skill and approach that you're using, technology that you're using. Then there is the interpretation of the illness and the fear that one associates with that condition. It's because each chronic condition that you're going to have a massive fear and how you're going to deal with the symptoms. Then there's the decision from the patient, own self. Okay, I need to take an action. You are taking an action, you're prescribing the medication, and that's what's very, very important. But the action and the ability to control and then coming towards the end of that is really, really important.
What's more important is that this balance, this model teaches us to balance, like a weighing scale. And this is a real beauty model that's been developed by Howard Leventhal, who's a professor of behavioral medicine in the USA. And he really has created these concepts after studying our patients with chronic conditions. So here's another one from London, who's Professor Robert Horn, with whom also I've spent many years with. He also says that actually what people further do is weigh up these necessities and these concerns. Yeah? These necessities and concerns, and they become very specific as the disease becomes very specific. So it could be diabetes, it could be cardiovascular disease, it could be gynecology, or it could be rheumatology. They become very specific. So the necessity, how he says, is in this fashion. And it's in this fashion. So those ones who are really going to engage with you might be because they are better informed. It's because your approach with them is very innovative. It's because you're engaging with them. It's about informing them, and you're really, taking your science down to their level and telling them how this is working. It could be that they're understanding their problem as a result of that better informed. Responsibility also depends. I really need to do this. So the necessity is always held up high, and that also goes with affordability and them themselves about the motivation and the level of motivation that person has. So the necessity is always held up high, and the concerns, yes, they are there. Who wants to be on long-term medication, but they are lower. And the ones who are really challenging and the ones who won't engage are those ones low adherers, because their necessity is always plumped down and their concerns are always high-rised. This then becomes really worse as they have an interaction with you over again and again, because we are not now communicating our science or our plan in the way it's meaningful for the patient. So their fears, their worry about the side effects carries on being a problem for them. Their lack of understanding, then it becomes a conveyor belt for them, going round and round and round, and in the motivation is also a key for them. What Rob Horn says, actually, you got to accept that not every person does this intentionally. There are these unintentions, which means that there are capacities and resources, and these become very practical barriers, like affordability, finance. Some people can afford them, some people can't afford medications. So it becomes a practical thing. And you, as a clinician engaging, will know, I think the heart is there, I'm engaging with the patient, but because of the affordability, this is a problem. But you're still winning with them because you've got them connected. You've got them connected. The problem becomes here when you've got all the other factors going on, so the affordability and the pricing or whatever, but if you can't break through their belief system and their mechanism of engaging, then we are really losing them somewhere. When we come to our communication in clinic, we all think that we're doing a fantastic job. Until we really reflect and say, how well am I really doing? And is there anything that tells me how well am I really doing? If that's missing, then you might as well just come to work, do your 9 to 5, whatever it is that you do, and then go home. That's what it is basically. Because your perception and the patient's perception could be totally two different things. Let's look at the patient's list. The patient's list is that, take me seriously. Give me a good explanation and give me a good insight into the science of my disease. None of you're sitting here, there are some nurses, there are registrars, residents, other professionals. None of you could have achieved your degree without having the core knowledge. That's agreed, isn't it? But we accept and we expect our patients
to keep going around this dark room over again and again. Yeah, rheumatoid arthritis hai, isko ye. But actually, if we're not going to engage in a more meaningful way, we will carry on with that dark room. Patient wants centered communication. Patient wants reassurance. They want outcomes, and so do you, because you want to publish, and the more you publish, the more your institution then becomes recognized as an institution. And again, it's about setting goals with the patient and saying what is it that they can do and how they can help to achieve that outcome. So let's look at the consultation that you do and the balancing necessities and concerns. I don't know how well, so normally with this is normally a 1 week course, a 1 week module that I run, and then within this I normally do lots of role play and some workshops. I might invite Dr. Naveed and maybe somebody else and say, okay, let's consult, let's do a consultation. And we did this in some centers because they allowed us more time. And it was really enlightening afterwards. I'm thinking, God, kya kar rahe hain hum? So it was really, really enlightening. So it matters the way you initiate the session, and it matters the way you gather information, and it matters the way you construct your consultation. I don't know to what extent your theory about providing a consultation structure is embedded within your undergrad and in your postgraduate, but that is really, really important. Don't ever divert from that. If there is a structure, stay with the structure. Building the relationship, that personal touch is also important in that explanation. And then closing the session with a meaningful role for you as a clinician, and also giving the person, the patient, a job to do until you see them next. It's a massive list, and I won't have time to go into this, but you can read it as I'm talking to you. But the end line is that the last 3 bullet points, supportive, empathy, and using your inner kind of experience, is something that we are very good at doing. But at the top, it's all about developing new skills. So you might have acquired basic skills through your training and through your experience, but they need developing further. It's only then you'll be able to keep the patients on their necessity bar high if your approach is very, very innovative and very new. And it has to be new to every single time that you see the person. And again, it's marrying and how do you gather that data in a 5 minute. And unfortunately, normally, as I said, I will do a workshop, but the time meeting doesn't allow me to, and how to employ some of these in your consultation. But at least you know that actually there's a lot more to learn how to consult a consultation. So these are the tips that I would give you. I would say what Rita is doing. So she's doing a really fantastic job, and she's she's challenging all of you sitting here and saying it can be done. Kyun nahi kar rahe hum? Yeah? Screen and collect data. If you can't do it while the patient, because she's inspiring so much. She's a bionic woman. She's absolutely a bionic woman. So if you can't collect it because you are still at the early stages of your career, find a way of collecting the data on your outcomes. Decide as a team, as a speciality, which data you want to collect on patients. So it becomes more meaningful for you, so that you collect it over a 6-month period, even if it's just an evaluation, simple evaluation. Kya hum learn kar rahe hain, hai na? It may be that you want to learn when is the patient pitching up? What was the delay of the patient pitching up? Kab ye problem shuru hua? Kab ye this or the other? Yes, that is part of your consultation of the gynecology, certain core problems in the gynecology. But maybe there is something that you want to obtain from the patient themselves. Yeah? So collect that data in a meaningful way, because that's the only way it's going to give you a story. The use of visual material, totally, I can come back to that when I explain the rheumatology example to you in a minute. What about sharing disease parameters? How many of us
turn the screen round to our patient and say, you know, the CR inflammatory markers, ये blood test थोड़े से high है, ये हमको ये indicate कर रहे हैं कि कितनी inflammation है जोड़ों में, और so it looks like we have to carry on with a higher dose, so we have to add something else in. It may be in your gynecology that there are some core key blood tests that drive and become more meaningful for you. They've got to be meaningful because you're making the decisions. So why not share them with the patients? And I'll show you a way that we are doing it in rheumatology. And the rest of the things is about diagrams and really kind of getting this necessity and concern framework. And I recognize that not every department is going to have a computer in front of them in clinic when you're consulting, but use a piece of paper and a pen. Huh? So let's look at the examples then from us. So for us, we know that rheumatology, particularly rheumatoid arthritis, let's say, for example, is an autoimmune condition. Yeah? So how do we conceptualize that to a patient? ये autoimmune condition है और आपके जो सूज जाएंगे और ये methodrix से ले लीजिए. How do you think? Here I would normally do a role play again, but I haven't got the time, unfortunately, time permitting. But so what we have thought about is actually when the patient comes in and once all the investigations are done, blood tests are done, then what we normally do is look to see how we can communicate that message, how can we communicate that science. So we are pretty fortunate over this.
Kanta, can you give one example? Can we have one of our person, one role play, so that that will be better.
So let's say
Ask somebody, one of our fellows who do rheumatoid arthritis every day.
yes, shall we do a role play then before
Yes.
I move on?
That will be better because it's practical, then people can get
Is there
some tips.
anybody from a registrar or resident from rheumatology here?
So one of you can come, anybody.
Aajo.
Hafiz, you want to do, or Funky, or Koshi, or whosoever, I don't know. Because it will be better if we have practical, otherwise it's just boring to listen. Right. Who wants to do? They can't
I
decide
need
one.
one patient as a volunteer and somebody from rheumatology. Aajo.
Come, one of you.
Come on.
So Funky is Poteng.
Professor Agrawal has put you in the light.
Patient, anybody can be a patient.
Anybody can be a patient.
But the real patients are actually better.
But who's the real patient?
आप बने patient.
आप बने patient. That's all thing. चलो आ जाओ. That's the
I
best.
won't teach you.
हाँ, ये पकड़ो.
Best of your activity.
That will be better.
Yeah, I'm the patient.
Very difficult to convince patient. Patient.
Mind games.
I don't know. Yes.
As a doctor, you have to take history first. And I'm an illiterate patient.
Yes. Let's see. That will be better otherwise. Yes,
It's more difficult to be a patient actually. Because it's more hypothetical.
अगर difficult बनना पड़ेगा अभी
I have to be a difficult patient.
मैं आपको बताऊंगी कि क्या करना है.
क्या कहते हैं?
No, I can say I'll let me play the game.
आपको हिंदी नहीं आती.
आती है. आती है.
Let me be the patient.
Fancy me being in
It's
India
much-
and saying to somebody आपको हिंदी नहीं आती. Oh.
It is much more difficult for me to play the role that you want to play than a hypothetical role I would rather.
So can I just give you one hint?
Okay, you give. Maybe you can write down a few points. What
नहीं
sort
मैं
of things.
सिर्फ कुछ बताऊंगी आपको.
Of course, that's what I'm trying to do.
अच्छा. ठीक है. Okay, so your role is basically here's a new patient. You've done all the investigation and you call them back up now for engaging. हाँ शुरू हो जाए.
आपकी जांच अपडेट है ना?
क्या जांच?
जांच जो पिछली बार कराने को बोला था.
Oh, they are an old patient or a new patient?
The second visit. Second visit.
Okay, second visit.
So normally If it doesn't happen in your country, please
So she's a
accept
new
my
patient. I thought I was
apology.
new
नहीं नवे patient है आप, आपका
हाँ.
brand new है.
Yes, that's what.
Okay.
I don't understand what
नहीं आप
investigation.
नवे हैं.
नवे हैं.
This is a new patient. You've done all the investigations. You've done the X-ray. You've taken all the bloods now. You've called the patient back to say that's
So it's
okay.
a second visit.
Second visit, able as we have a second visit.
हाँ, पर नवे हैं.
Counseling to second
आप नवे हैं
second visit.
पर आप सेकंड विजिट पर आए हैं.
आपका सब रिपोर्ट आ गया है, रिपोर्ट आ गया है, एक्सरे आ गया है. That's what you want ना? एक्सरे आ गया, रिपोर्ट आ गया, डायग्नोसिस बन गया है. तब आगे चालू करो.
You already have.
I think that's how Professor Mishra.
Okay, Mishra, she wanted one person for other. Suppose as a RA patient. You want to?
I know. Actually,
Dr. Mishra will be better.
Actually, that's why male patients are
People will
more
confuse
diagnostic
everyone.
because then.
Able, let Dr. Mishra be there. Yes. Yes, yes. He failed to give.
I will teach Abel separately.
Yes.
Professor Mishra. आपके ब्लड टेस्ट हो गए हैं और आपके एक्सरे और सब कुछ हो गया है और आपको दोबारा बुलाया गया है और
Yes, yes.
सभी हमारे
You need to define the role first much better.
आप जांचें लेके आए?
हाँ
Is it a
हाँ.
microphone?
हाँ, बिल्कुल.
वो तो सारे आपके कंप्यूटर में होंगे।
पर एक्सरे तो आपको लेकर आना पड़ेगा ना काउंटर पे.
हाँ वो तो एक्सरे है, ये ले लीजिए।
इसमें आपके गठिया की टेस्ट पॉजिटिव आए हैं तो ट्रीटमेंट
तो इसका मतलब क्या? कि अगर टेस्ट
जो
पॉजिटिव
आपको जोड़ों का दर्द वगैरह हुआ है जो हमको शक था कि ये गठिया की टेस्ट था इसलिए हमने कंफर्म करने के लिए कराई थी वो खून में तो पॉजिटिव आ गई है एक्सरे में भी काफी डैमेज लग रहा है अभी तो अभी
क्यों
हमको
हुआ ऐसे?
क्यों हुआ ये तो नहीं बता सकते किसी को नहीं पता है
ये टेस्ट में पता नहीं चला?
टेस्ट में तो यही
10
पता
minutes
चलता है
test,
ना
that's the
कि
best.
हुआ है क्यों हुआ है वो तो बहुत सारे कारण होते हैं
तो फिर क्या करना पड़ेगा?
अपनी दवा शुरू करना पड़ेगा
कितने दिन में मैं ठीक हो जाऊंगी?
दवा तो अभी हम एटलीस्ट देखो ये जो गठिया है ना ये ट्रीटेबल कंडीशन हम नहीं बोल सकते ये हम दर्द वगैरह कंट्रोल कर सकते हैं और ट्रीटमेंट
मतलब
लंबे
मैं
समय
ठीक नहीं हूँ।
नहीं आप ठीक दवा से आप कंट्रोल रहेंगे लेकिन ये जड़ से जाने वाली बीमारी नहीं जैसे बीपी और डायबिटीज के लोग दवा लेके कंट्रोल में रहते हैं वैसे दवा कंटिन्यू रखना पड़ेगा आपको
जिंदगी भर।
एटलीस्ट 5 से 7 साल तक तो कंटिन्यू रखना पड़ेगा फिर हम देखेंगे आपका रिस्पॉन्स कैसा है
अभी तो हम एक किसी से मिले वो तो 10 साल से दिखा रहे हैं।
डिपेंड्स कैसा रिस्पॉन्स आता है ना अभी की टेस्ट तो ऐसी है कि शायद लंबे समय तक कंटिन्यू करना कि जो दवा से आपका जो और डैमेज होगा वो तो नहीं होगा जो एक्सरे पे अभी डैमेज दिख रहा है वो तो सिर्फ एक्सरसाइज वगैरह से कंट्रोल हो पाएगा
तो मतलब इसके आपके पास कोई परमानेंट ट्रीटमेंट करने के
परमानेंट
लिए
ट्रीटमेंट
कोई
नहीं है ऐसा नहीं है कि सर्दी खांसी हुआ है 5 दिन दवा लोगे आप ठीक हो जाओगे ऐसे नहीं होगा दवा तो लंबे समय तक लेना पड़ेगा
फिर कब आना पड़ेगा फिर?
अभी हम दवा लिख के देंगे आपको फिर कुछ टेस्ट करा के आपको 1.5 महीने बाद हमको दिखाना होगा कि दवा ठीक तरह से चल रही है कोई साइड इफेक्ट नहीं हो रहा है
साइड इफेक्ट मतलब क्यों?
दवा से देखो हर दवा का तो साइड इफेक्ट रहता है दवा का हम साइड इफेक्ट मॉनिटर करना पड़ेगा हमको कि
तो क्या
आपको क्या
होगा
साइड
उसमें?
इफेक्ट हो रहा है अभी हम जो एक दवा शुरू करेंगे उसमें ह्यूमन हो सकते हैं पेशेंट भी आपके कम हो सकते हैं तो वो सब हमको देखना
इसका
पड़ेगा
मतलब रोज मेरे को दवा लेनी पड़ेगी।
रोज दवा नहीं है
तो उसमें खतरा भी है।
सब दवा का रहता है वैसे ये दवा का भी है
तो फिर ये तो बहुत कुछ ठीक नहीं है।
सब भी अभी बीमारी है तो सब कुछ तो ठीक नहीं रहेगा पर हमको सामना करना है इसका एक्सेप्ट करना है
किस चीज का एक्सेप्ट करने की ये ठीक नहीं होगी?
Actually, at this stage, if you have it in English, it might be easier because
नहीं doesn't matter because most people know Hindi ना.
content might.
ये आप दवा देंगे और मेरे को ये
देखो दवा देंगे तो एटलीस्ट हमको 2 to 3
कोई
मंथ्स
और बढ़िया नहीं है। इतना सारे रिसर्च हो रहा है, कोई ऐसे कोई दवा दे जो कि
नहीं जो दवा दे रहे हैं वो काफी अच्छा दवा है पर इसको थोड़ा समय लगेगा एक्ट करने में कम से कम 2 से 3 महीना लगेगा इसका असर होने में आप उसके बाद आपकी लाइफ काफी कंफर्टेबल हो जाएगी आप सब कुछ रूटीनली कर
आप कितना
पाएंगे
ऐसे पेशेंट को ट्रीट कर चुके हैं?
बहुत सारे
बहुत सारे।
और अगर आप
तो क्या
रेगुलरली
क्या उनका खतरा हुई है, मतलब उनका क्या साइड इफेक्ट हुई है?
यूजुअली 90 to 95% दे डू फाइन, कुछ ऐसा कुछ प्रॉब्लम होता नहीं है, बट सेफ साइड वी हैव टू मॉनिटर। तो पहले जब हम दवा का डोज धीरे धीरे बढ़ाएंगे तो हम
और
आपको
अगर मेरे
जब
कुछ हो गया तो मैं फिर कैसे कांटेक्ट करूँ आपको?
अगर कुछ
फिर
प्रॉब्लम
आप
होता
तो
है
एक
अगर कुछ प्रॉब्लम होता है तो आप कभी भी आ सकते हैं, नहीं तो जो अपॉइंटमेंट हम देंगे वो तारीख को आपको आना है।
उससे पहले भी हो सकता है।
अगर कोई दिक्कत हो रही है आपको तो आप हमको कभी भी दिखा सकते हैं।
मतलब लगभग कितना दिन होगा जैसे लगेगा कि हम थोड़ा बहुत ठीक
2 to
है?
3 months it takes for the medications to take full effect.
Okay, well done.
Good.
I thought I'm better.
What do people think? Let's take. Sorry, what's your name?
Pankti.
Pankti.
Yeah.
Pankti.
Yes.
Let's take Pankti's approach first. What do people think? And be honest, because this is why we are here to challenge. So Pankti's approach.
You can start from one side. I think that will be better. Start from one,
Going
ask them.
hard for, because look, we've got less time, so the more you engage, we can get it over and done with. Okay, what do you think about Pankti's approach? What do you, just tell me before I go on.
Just Navni.
अच्छा था, बुरा था, क्या था?
She was trying her level best to solve the patient problems. It was good.
She was trying to solve the patient problem.
She
That's interesting.
all what queries the patient put, she was trying to answer them.
Right. Okay. Thank you for that. Anybody else? What do you think?
कनेक्शन और कम्युनिकेशन अच्छा था, क्योंकि जो वो पेरेंट थी तो पेशेंट समझ भी रहा था और आउटपुट भी बात समझ रहे थे दूसरे को दोनों को।
Okay. Anybody else?
Patient question is very good. Question of patient.
Patient's questions were very good.
इतने experienced हो गए हैं ना patients।
I will put it in a different way. There are two levels for this. There are two levels of understanding. One is the patients, the problems and issues the patients are aware of. There are problems and issues the patients themselves may not be aware of. And then there are issues as a physician you want to convey even if patient wants it or not.
Yes.
So there are multiple levels to this.
Thank you.
In those additional levels, it is not really.
Yes. Thank you. Okay. So what do we think about the patient? Where is the patient coming from?
Urban setting.
Dusk.
Huh? Go on. No.
Urban setting.
Huh? Urban? Right, okay. I mean, okay, let me rephrase that. When we normally say where is the patient coming from, what we mean is normally, what is the patient really trying to get out of this consultation?
He wants to get well.
See, patient, what he wants to understand is what his problem is. He actually is anxious to know.
Yes.
He wants to get assurance from the doctor, yes, that the treatment which the doctor is going to prescribe is actually going to work for me, and if I have to look for any other alternatives, any other information which I want. So he's just trying to get that reassurance so that his anxiety levels due to the anxiety, or you can say stress, due to the disease condition. Yeah, actually we all have that.
Yes.
Even if we take it from other perspective, even in personal life also, if you think from the perspective of the patients and the patient's relatives also,
Yes.
why do you think there are so many incidences of, say for example, violence against doctors?
Yes.
Or it is because of that anxiety, stress.
Yes.
Of course, there are certain issues related to people that we will not discuss apart.
Of course.
Mysteries.
Yes.
But yes, at the core of that is the patient wants reassurance.
Yes. Okay, thank you very much. So let's ask the patient. So your name is Jagat Sharma. So आपको कैसे लगा मिस्टर शर्मा?
कुछ तो ठीक लगा कि उन्होंने कहा कि इस बीमारी का इलाज हो सकता है,
हाँ.
बट कुछ ठीक नहीं लगा कि पूरा ठीक नहीं होगा और
हाँ।
कई सालों तक कंटिन्यू पड़ेगी
हाँ
और उसमें रिस्क भी है कि
हाँ
और साइड इफेक्ट भी हो सकती है
हाँ
और पता है कि चांसेस क्या है, मतलब मेरे 100% ठीक होंगे
हाँ हाँ
नहीं।
हाँ। तो आपको ये समझ आया कि बीमारी क्या है?
हाँ बस थोड़ा बहुत समझ आया कि गठिया की बीमारी है।
गठिया की बीमारी है, थोड़ा बहुत तो समझ आया। ओके नवनीत, हाउ नहीं वो तो वहाँ पंक्ति okay, let me take over. I'm not going to say that this is perfect, but this is how we are doing it differently. Before, we were doing exactly this. Okay? 5 years ago, or maybe even less than that, we were doing exactly this. And this is where the disconnect and the opportunity for engagement was lost. I'm just going to take a different approach and have a think about that. And it's very simple. And then you tell me whether it's useful or not. Take care, Bhakti? Okay. So I just need do the slides for me again. Okay. So that's fine. Does you see now?
A little bit louder. Down.
I can't hear louder. No, there's no microphones at all.
हैंड माइक कहाँ गया अपना?
Mic.
हैंड माइक चला गया? इसमें बोलने में चलेगा इससे?
It's just that I can't talk really loud, and then yeah. Okay, I'll try. कैसे हैं आप? मिस्टर शर्मा ठीक है?
ठीक तो नहीं हूँ।
हाँ ठीक तो नहीं है ना? वो
ठीक तो
तो
नहीं हूँ।
हाँ हाँ
इसीलिए तो आपके सामने आया।
हाँ absolutely अब बिल्कुल सही कह रहे हैं, ठीक तो नहीं है। मुझे भी थोड़ी सी ये दिस रही है सोच पेन हुई है हाथों में। तो आप आए थे ना 2 हफ्ते पहले और हमने बहुत टेस्ट किए थे और टेस्ट किए थे हाँ
काफी खून दिया था।
जी तो अभी हमको सारा मेरी पंजाबी भी बोलने में चल रही है ना सारी ना हमने सब ब्लड टेस्ट
He'll get it. He'll just get it.
ब्लड टेस्ट किए थे और एक्सरे तो अभी हम ये देखना चाह रहे हैं कि स्टोरी अब कहाँ पर जा रही है। ठीक है तो मैं पहले आपको ये बताना चाहूंगी कि ये ब्लड टेस्ट है जो सभी आ गए हैं तो इसका जो भी हमको कंक्लूजन लाना है तो हमें ये लग रहा है कि ये रूमेटॉइड आर्थराइटिस जैसे कि गठिया होता है वो होने का चांसेस है, पर चांसेस क्या एक्चुअली है और ट्रीटमेंट भी लेनी पड़ेगी और
Yes.
थैंक यू ट्रीटमेंट भी लेनी पड़ेगी वो भी जहां पर हम हैं ऐसा लगता है कि ट्रीटमेंट लॉन्ग टर्म के लिए लेनी पड़ेगी, पर मैं ट्रीटमेंट की बात बाद में करूंगी। पहले मैं ये चाहूंगी कि मैं आपको ये थोड़ा सा जानकारी दूंगी कि बीमारी ये जोड़ में ये सोजन ये क्या है। ठीक है ना, हम सिर्फ 3 मिनट यहाँ पर स्पेंड करेंगे। तो ये आप देखेंगे जस्ट वंस अगेन, ये आप देखेंगे कि हमारा जो फाइटिंग सिस्टम होता है ना, ये बीमारी फाइटिंग सिस्टम से हमारा जो ऑटोइम्यून सिस्टम हम जो कहते हैं ना फाइटिंग सिस्टम से शुरू होता है और उसमें ये होता है कि जैसे कि हमारे सोल्जर होते हैं ना जो हमें प्रोटेक्ट करके रखते हैं अंदर से, तो वो सिस्टम में कोई प्रॉब्लम आ जाता है। प्रॉब्लम किसी बात ऐसा होता है कि वो प्रॉब्लम बिना बताए जैसे हो जाता है, ऐसा भी होता है किसी टाइम वो फैमिली में भी होती है बीमारी तो इसीलिए हो जाता है। और आपने लास्ट टाइम कहा था कि आपकी फैमिली में ये गठिया है, तो हो सकता है कि वो सोल्जर आपके पास भी हो। तो ये जो फाइटिंग सिस्टम है ना, तो ये मैसेजेस जो भेज रहा है ना, ये सोल्जर जो भेज रहा है कोई लो नहीं है पर ये भेज रहा है। ये भेजने की जो बात हो रही है इंडियन सिस्टम से, तो ये सोजन पड़ रही है। तो ये अगर सोजन पड़ेगी तो ऐसा लगेगा आपको कि जैसे पूरा घर जल रहा है, जैसे कि जोड़ जल रहे हैं। ये जोड़ जल रहे हैं तो ऐसा लगेगा कि हाँ जोड़ जल रहे, इसका क्या असर मैक्सिमम क्या हो सकता है? इसका असर बहुत हो सकता है मिस्टर शर्मा। ये हो सकता है कि हम ये आप देख रहे हैं कि पिक्चर बहुत ब्यूटीफुल है ना? ये ब्यूटीफुल पिक्चर है, तो अगर हमने कुछ नहीं किया इसके बारे में, ये डैमेज थोड़ा सा होने लगेगा बॉटम से। तो जोड़ जैसे कि क्या कहते हैं, ये कार्टिज है जो, वो थोड़े से डैमेज होने शुरू हो गए। तो एक बहुत इम्पोर्टेंट है कि आप हमारे साथ पार्टनरशिप बना के हम आपको ट्रीट करना चाहेंगे। हाँ, हम ये बात मानते हैं कि ट्रीटमेंट जो है वो बहुत स्ट्रॉन्ग है और उसके ब्लड टेस्ट भी हैं और लाइफ लॉन्ग के लिए भी हैं, पर हमारा मकसद ये है कि एक हम ये हमारा मकसद ये है, ये जो सोल्जर है ना, ये जो थोड़ी सी क्या कहते हैं कि ट्रबल बना रहे हैं ना, इन लोगों को शांत करना होगा। हमारा ये मकसद है। अगर हम ये करेंगे तो हम ऐसा कर पाएंगे। ये जो मैं आपको ट्रीटमेंट की बात बताऊंगी ना, मेथोट्रेक्सेट जिसकी मेडिकेशन का नाम है, वो एक तो ये आग जो चल रही है इस सिस्टम में कम करेगी, और दूसरा हमारा जो एम है कि आपको कोई डैमेज ना हो।
कैंसर
नहीं, कोई कैंसर नहीं है।
ये तो हमने सुना था कोई कैंसर में लिख दिया।
हाँ, आपने बिल्कुल सही सुना था। हाँ, सही सुना था। हम ये थोड़ी सी तोड़ पार कर देते हैं। मैं सिर्फ पहले आपको ये बताना चाहती हूँ ना, ठीक है ना? सो ये हम दो चीजें करेंगे। एक तो ये जो फायर, ये जो सोजन हो रही है, इसको कम करेंगे, और दूसरी कि ये जोड़ों में आपका डैमेज ना हो, दो, है ना? ओके। तो जब ना क्लिनिक में आएंगे, अब जब आते हैं क्लिनिक में फॉलोअप के लिए आएंगे, तो हम चाहते हैं कि जैसे कि very good point about describing about the diabetes, an example from diabetes, that was a very good one. So जैसे कि डायबिटिक पेशेंट होता है, जैसे कि ब्लड प्रेशर पेशेंट होता है, अगर आपको ये मालूम चले जाए कि कितनी शुगर बढ़ी हुई है, तो आपको पता चलता है कि हाँ, एक्चुअली मुझे लड्डू नहीं खाने चाहिए और ये नहीं करना चाहिए। सो सिमिलरली हम भी ऐसे करना चाहेंगे कि आपकी डिजीज एक्टिविटी स्कोर मैंने जो कैलकुलेट की थी 2 वीक्स अगो, वो थी 5.9। हाँ, तो इसका मतलब मिस्टर शर्मा आप वो रेड में बैठे हैं। इसका मतलब ये जो मैसेजेस आ रहे हैं ना, फाइटिंग सिस्टम ये सोल्जर आ रहे हैं बिना मतलब से, कोई लड़ने की बात नहीं है, पर फिर भी आ रहे हैं, मार्च कर रहे हैं, तो वो रेड में हम बैठे हैं। हमारा मकसद यही है कि आपको ये ब्लू में लाया जाए पहले, और फिर हम आपको ये येलो जोन में, फिर ग्रीन जोन में लाएंगे। और ये डिजीज एक्टिविटी स्कोर है ना, आप कुछ भी याद कीजिए ना कीजिए, पर आप ये डिजीज एक्टिविटी स्कोर जिसको हम डैश कहते हैं ना, ये जरूर आप याद रखें। और जब भी आप आए ना, अगर मेरे को बताने का मेमोरी नहीं है, तो आप मुझे पूछे कि मेरा डैश क्या है, ओके? और उससे आपको ये पता चलेगा कि आप बैठे कहाँ हैं, ओके? ठीक है ना? और अगर आप ये रेड जोन में हैं, तो फिर मेरा मकसद ये होगा कि ये मेथोट्रेक्सेट का डोज बढ़ाया जाएगा, जब उसके साथ और भी ऐड किया जाएगा। ऐसा भी हो सकता है कि हम आपको जैसे कि और मेडिकेशन जैसे एडवांस थेरेपी भी दे सकते हैं, क्योंकि ये सोल्जर है मान नहीं रहे, हाँ? तो हमारा ये मकसद होगा कि उन लोगों को हमने होल्ड ऑन करना है, हाँ? ठीक है ना? तो ये तो एक बात। दूसरी, आप जब यहाँ पर जाएंगे ना, हम ट्रीटमेंट की बात करेंगे, जस्ट बेयर विद मी फॉर 2 मिनट्स। तो जब आप यहाँ से जाएंगे, मैं चाहती हूँ कि आपके पास फोन है और फोन को आपको यूज करना आता है, क्योंकि मैं तो आपको आज सिर्फ 10 मिनट मिलूंगी, पर ये जो हमारी है ये आपके साथ रहेगी। पर मैं चाहती हूँ कि आप इसको रिकॉर्ड करें और मुझे बताएं नेक्स्ट टाइम आप जब आएंगे, वे कौन सा जोड़ सूजा होता है, क्यों, क्या, कि कितना फ्लेयर अप हो गया, आई डोंट नो द लैंग्वेज हियर,
बीमारी कैसी रही,
बीमारी कितनी बढ़ गई या कम रही। तो ये हमारे लिए बहुत इम्पोर्टेंट है, कितना पेन, जहाँ आपको ये जो टायर्डनेस फीलिंग, ये बहुत इम्पोर्टेंट है। आप नोट कर लेना, ठीक है ना? अगर सोचे हो जोड़ तो फिर थोड़ी पिक्चर भी खींच लेना, फिर जब आप आएंगे तो फिर हम देखेंगे, ठीक है ना? ओके। तो ये मैं आपको कार्ड दे रही हूँ और इसको आप जाकर ना किसी को आप भी यूज कर सकते हैं। ये अपनी जंग प्रोजेक्ट जो है वो आप सुनेंगे, वीडियो सुनेंगे, पेशेंट्स के एक्सपीरियंसेस सुनेंगे और आपको थोड़ा सा जैसे कि दिलासा मिलेगा, थोड़ा सा रीअश्योरेंस मिलेगा, हाँ? क्योंकि आप अकेले नहीं हैं इस बीमारी के, आप अकेले नहीं हैं। हमारा मकसद मिस्टर शर्मा इसको सिर्फ कंट्रोल करने का है। अभी हमारे पास कोई भी क्योर नहीं है, हाँ? पर ये हम आपको प्रॉमिस कर सकते हैं कि हम कंट्रोल इसको करेंगे, पर तभी करेंगे अगर हमें आपके साथ पार्टनरशिप होगी तब। अगर आप हमारे पार्टनरशिप नहीं होगी तो फिर बहुत डिफिकल्ट होगा, ठीक है ना? मैं ये जानना चाहूंगी कि आप ठीक है ना ये इंफॉर्मेशन के साथ, और क्यों आप और कुछ सोच रहे हैं जहाँ आप मुझे बताएं।
मैं तो ये सोच रहा था कि अगर आप किसी का ऐसे बीमारी हुआ है और आपके ट्रीटमेंट में ठीक हुआ है,
हाँ,
उसका कांटेक्ट हमें दे दीजिए ताकि हम बात कर लेंगे उनसे।
हाँ,
आपके पास तो समय नहीं है,
हाँ,
तो और दूसरा ही दवा कहाँ से मिलेगी और
हाँ,
उसका खर्चा कितना आएगा।
हाँ, हाँ,
आप बता रहे थे कि
हाँ जी, हाँ जी,
और दवा के साथ क्या और
हाँ जी, हाँ जी, हाँ जी,
क्या हम दही खा पाएंगे,
हाँ जी, हाँ जी, हाँ जी,
चावल खा पाएंगे,
हाँ जी, हाँ जी। सो वो हम टॉपिक के बारे में बाद में बात करेंगे, हाँ, मेडिकेशन के बारे में। पर आपको मैं पहले ये मेक श्योर करना चाहूंगी कि आपको समझ लगी
हाँ,
हम क्या करना चाह रहे हैं। आप हमको आपकी पार्टनरशिप है ना, ठीक है ना? कोई और फिक्र या और कोई दिमाग में कोई बारी बात तो नहीं चल रही इस बीमारी को लेकर? मुझे मालूम है कि ये कॉस्टली है या कुछ भी है, उसके साथ भी हम थोड़ा सा उसके बारे में भी हम बात कर सकते हैं इन मिनट, बट आपको समझ लग रही है ना? ठीक है ना? ठीक है, श्योर है? ओके, सो अभी then I will go on to the methotrexate, and then I will spend another 5 minutes on talking about the methotrexate. Methotrexate is a disease-modifying anti-rheumatic drug. It's there, the side effects of this, and the fact that in research this is a very common medication we use, and it's very safe to be used. And why do we need to monitor the patient 2 weekly to begin with for the first 3 months, and then it will be monthly? Are these suppressing of the soldiers and this, that, the other? Okay. So these slides that have been put together are with our health psychologist and with our group of patients. So this is what we put. I've only bought a few slides because I know that we haven't got the time to go through all of them. Okay. So, come back. So tell me, what do you think about that? Just as an isolation, what do you think about that?
I really like the part where you said about the recording, because I think that's very good. Like, so when they come back, they're already ready with what they have, and then we can analyze it and about the pictures, because many times they say that Sujan I thi and they took a medication and it went. So you don't know whether to actually trust it or no, because they are always very apprehensive. We don't know whether actually they had a swelling or to increase the medication
or the number of flares that they had.
Yeah, and the number of flares. So that would give an indirect objective assessment of the patient.
Okay. Anything else that you found useful? To enhance your consultation?
Also about the explanation of the disease and the disease activity. Like that will tell the patient where the patient stands and what the patient has to achieve.
This one?
Or what is the aim of the treatment? Like the patient will know where we are going in our consultation. Like probably a year down the line, the patient knows where he'll be or what he has to expect out of it.
Yes. Okay. Anything else?
These two concepts.
Okay. Anything else that comes to mind? So what I would say, don't let the patient know until you move on from this. This is what I do. I know that I might have more time, as Mr. Dean said earlier, that आपके पास तो time है. And it's not true that we only get 5 patients. We get more patients. But we do have, because the trust, that's the way our structure of the appointments have been, that we get, for new patients, we get 15 minutes.
You've got these slides with you for the patient or in the pictorial format?
Hanji. So I have given them to Avinash to do that in Jaipur. So let's give it to the patient. How did you feel this time, Mr. Sharma?
No, I
We always say you
I always
want to reduce the number of environment.
the important thing is that you said that there is something to monitor, and it is like sugar to diabetes, that there is something to monitor and there is a goal.
Target. Set a target.
But
No?
if your goal is to make number of
And you can measure that. So every time when I come, I can ask what is my score. So then that is something
I just want one.
good about it.
Did you find back again?
These were horrifying slides.
Back again? Horrifying. It's our aim to horrify you, because if you don't horrify, I won't engage you. Yeah? So did you find...
And this bit I don't know whether a patient would get into it. The joint and the small molecules. This might be okay.
So
But
do you
the
think...
one, the slide before, a diagram of a joint and
Yes.
that may not sit in.
But even if it's anything, because you said that this is a fantastic unit for you, you're using technology. But if it's anything simple, do you find that was better enhancing your consultation? Because sometimes we can't translate the science and the seriousness of that science to the patient. And you only have 5 minutes or 10 minutes. Yeah? The time is short, and here's an opportunity, and it's really important that Mr. Sharma stays intact with me. So when he sees me down the corridor, 1 year down the line, he's going to say, Pankti ne hana itna acha explain kiya tha na, to, he will come. And what will happen as a result of that will be, because then at the next appointment, so I have separate slides which I haven't brought with me on the follow-up, is about sustainability. So what we do is, I don't know whether that's the case for you guys in your systems, we can draw some diagrams within our CRP. When you click onto the CRP, I think Avinash did do that he said that we can draw a graph. So we can say, Mr. Sharma, this is great news. We are driving everything down. Again, it's about using different approach, different techniques to engage the patient so they stay engaged. As a result of that, what will happen is that you will get less follow-up from that patient. Would you agree with that? You will get less follow-up, less headache from that patient. So if you've reduced your 6 visits with this patient, you can reduce them down to 4, first of all, and then as you get better at using that approach, you can actually reduce 3 visits. First visit, investigation. Second visit, you initiate the treatment and explain and take an approach. Third visit is your follow-up. In our system, in the UK, then we give that to the nurse specialist. Then they will monitor and they will carry on and they will do the blood test. And I know in the absence of that, because you haven't got that workforce adding value to your system, and Anamita was just telling us earlier that actually it doesn't matter how many times she writes in a proposal or a bid, that is a need. But can you imagine that then Professor Mystery can only focus on the important things that he needs to do, and the workload is shared.
I want to make one.
थोड़ा सा आप यहाँ पर आ जाएं. Even I'll come back to you. You had a point, no?
Like everything in life, even counseling has its appropriateness. I would like to quote from the book Mind Over Medicine. It's written by a gynecologist who later turned into a counselor. I've forgotten her name, something from L, it's Linda something. But the book is Mind Over Medicine, and she did a lot of research, and she explained one situation in which the patient was told that the patient has esophageal cancer and it's last stage and not treatable and you have only 6 months to live. And the patient died within 1 month. And when they did an autopsy, it was only stage 1 cancer. So the patient died because of the negative counseling. So we have our limitations. Whenever we counsel, we should try and be appropriate. Don't overdo it, don't underdo it.
Yes.
So that's my statement.
Yes,
Thank you.
Absolutely.
And I think that's really important for cancer patients, cancer specialists, that you have to really make sure that your investigations and everything before the patient comes in, that you've got that in mind. And I would just like to say that this kind of consultation is not counselling, it's consultation. It is consultation, but you're borrowing some skills. That
But
and an
whatever you
approach.
say has a great impact on
Yes,
the
yes,
patient.
Absolutely. So, Abel.
See, there are two sides to it. You have to gauge patient knowledge, patient expectation. Then you have to have your own model of what the appropriate patient knowledge and appropriate expectation should be. So your interaction is designed not only to gauge that information, but also to change patient's understanding of these two things. Right expectation is very important. If patient has too much expectation, even if you do very well, patient will be unhappy and may not come back to you. If patient has too little expectation, then patient will not have any hope and patient won't take medication. So you have to get the right amount of scaring right up while not making it hopeless.
Yes.
And so, and keep that engagement. So you have to have a mental model of what that information is.
Absolutely.
And so initially when you try to do that, you take a long time, but as you do more and more, your time will come down.
Absolutely.
This is something I shared the article with. There is an article on efficiency learning curve.
Yes.
As the number of things you do doubles, the efficiency improves by say
Yes.
a certain percentage of it.
Exactly.
So this is so you have to incorporate it. That's why in clinic patient, when you do examining the patient, the more you do, the faster you become.
Yes, exactly. Thank you very much, Abel, for that idea. So, more importantly is that the behavior, so expectations, meeting expectations, and getting to grips with what the patient wants, and relaying what you as a clinician wants, and above all is about that engagement and the satisfaction that the patient will get at the end of it. And the change. Do you think that you will now change the way you think?
Yeah.
See, so if the behavioral change comes, then you've won. If the change doesn't come, and they keep coming up, and if Mr. Sharma is still asking with your first approach, let's take, for example, if Mr. Sharma is still saying a year later, but ye kya hai? Ye kyun ho raha hai? Ye theek kyun nahi ho raha? What do you think?
The patient has not understood what the disease is.
What do you think the consequences of that is?
He'll have mistrust, he'll have mistrust in the doctor, the treatment, poor doctor shopping, eventually miss medications, worsen his own disease.
Compliance. Exactly. So we are now sending the person off on a different journey completely. So they were in a dark room when they came to us, but now because our engagement, the only thing we did was give that prescription. Now the prescription won't even be taken. Yeah, that's where we need our patients. So thank you guys so much. Let's have some. So, okay. I think this is what I would say is. I guess what we are good at is developing models. And what we are good at in the UK is monitoring the long-term outcomes, and Amita knows this very well. We are very good at now looking at the approaches, and oncology has made the start in our country because they have timelines to give to the patient. And so therefore, their clinicians are very quick on skilling themselves up much quickly than anybody else, I think, with any other chronic condition. Because it's so important, isn't it? Breaking bad news and telling the person it's traumatic, isn't it, really? Huh? And an acute setting, also people being in ITU, you're not just dealing with the patient, you're dealing with the family. So those are the clinicians who would really acquire, go out of their way, do further courses, skill up. Yes, so they'll train themselves. But we are now following that model in other, so diabetes, and particularly with people with dealing with ethnic patients. So we deal, about a third of our patients are from South Asian population. Yeah? And the challenge again is, as the Professor Misra said right at the beginning, is about cure. It's in our blood. है ना? जैसे कि हम diabetes inherited किए, other things we inherited, है ना? We inherit this thing. है ना? So even our UK-born Indian patients will say, but you know, when are you going to get this better? Am I never going to get cured? That's the first thing that will say. And you sometimes you're really be surprised when you're born here, you're educated here, but still you're expecting a cure. But why shouldn't they? They want to know, what have you been doing? Is there any research? Can't they ask the question? But my wife's colleagues then will say, oh God, here we go again, another person is asking for a cure. But it's about conceptualizing that and saying, you're absolutely right, we should be able to tell you that there is a cure, maybe not yet, maybe in another 5 to 10 years' time. But abhi nahi. Abhi hamare paas koi cure nahi hai. Okay? Okay, this is what we tend to kind of say, that we haven't got the cure at the moment. So you're not giving any false information, but you are giving them a picture to say, we are working hard. If you say, no, iska cure nahi hai, it kind of means that, well, how do you know what you're doing? Yeah? Because we are so linked with evidence-based research, I come from an academic job and I come from an academic unit. So for us to talk about research findings, percentages, this percentage, that percentage, we do it a lot. And what we find is, this is why we get awards. This is why our centre is outstanding, is because we are engaging, and I don't want to comment on anybody else's. Able.
This is the answer I usually give to people who ask for cure. I said, if you take drugs properly and if you are lucky, we may be almost normal, that it's not possible for somebody who doesn't know you to say that you have a disease. So, and suppose you get cured, we wouldn't even know. There's no way of knowing. Most of these diseases, there's no, suppose someone is doing very well, it is not possible for us to know whether you are cured or not.
Yes.
So that is why we can't talk about cure.
Yes, so yes, exactly. So you just say we haven't got it at the moment.
You don't even know if you are cured.
Yeah, exactly. So you're absolutely right. So if that works in Indian context, then say that. So then is the patient charity organisations. We are pretty fortunate to use charity organisations in the UK. I don't know whether in your specialities you have user groups, and I know that Amita National has started to put together patients in group hers and user groups. They are very, 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 very powerful actually. When you put, really positive and innovative patients together, they become your volume. They become your volume, and those are the people who can then knock down the policies. They really do.
Actually, the educated patients are more useful in understanding, pushing the envelope into what are the challenges.
Yes.
Because they ask more tougher questions.
Yes, exactly. So if you then said to them, I need you to become my voice, meaning then they are now your power.
Actually, what you need is an information model kind of a thing. You have an information model. This is the kind of information you have to provide. This is the kind of information I need to learn from the patient. What are the worst case, biggest questions patient would ask? That should be the thing that is in the back of your mind when you're counseling.
Yes.
And this particular model expands when you have a really challenging, educated patients who ask the toughest questions.
Yes.
So because the uneducated patients won't ask you difficult questions.
Yes.
You have to push them to ask those questions.
Yes, that's right. So what I'm talking
But I don't
about...
agree. I think uneducated patients ask even more intelligent questions. They are much better. Their understanding is even better than the educated people because their mind is not cluttered with information from other sources. They are asking you information and they're assimilating information only from probably 1 or 2 sources.
Yes.
While people who are half-baked or half-educated are getting information from 10 sources and they don't know what is right and what is wrong.
Yes.
So they are more cluttered. So I have the opposite opinion.
That's more challenging. They will give you all kinds of wrong things.
That's right.
I don't
so
think.
if I just finish the presentation off then. So what I would like to say is that this journey of opportunity should remain as an opportunity. What we have to obtain is new skills, new knowledge, innovate ourselves, and also that consultation that we do with our patients, because that's the only thing that we are good at doing. And if we can't do that at its best, then we really should stay at home. Make it an opportunity, capture the patient's attention, the more attention you capture at the beginning, the better it will be for you later on. And I'd just like to leave you with this slide, that you and the patient are on a journey together. It's not just the patient because they've got the disease, but you because you are inheriting them. And I just hope that today you'll think that this journey has just begun for you.
You have questions at this end? Should we have
Should I
questions?
just present the options?
Okay.
Yeah.
there pres-
So what I would like to do now is actually you're talking about the university.
Yes.
Yes.
All right.
Yes.
Just check with me. That's okay.
Yeah, that's fine. Perfect. We are very informal.
So I'd like you to meet Dipankar Chakravarti. Do you want to do that?
Now you can do that. No problem. So Mr. Dipankar Chakravarti is based in Delhi and he represents the India Institute of University of Birmingham. So he's going to just tell us what are the opportunities available for us to learn these skills, be it in India or be it by going there.
Thank you, Professor Agarwal. Thank you, Dr. Mishra. And thank you all. It's Sunday afternoon, and I know I'm standing between you and lunch after this, so I'll be very, very quick. Kanta has already presented to you about her session on how to increase more engagement, patient engagement, and adherence. I'm going to talk a little bit, give you a little bit more information about the university and about our medical school, what kind of researches we are doing, and then Kanta will come back and present to you certain options or certain models that we have thought about that again could work with you in India, delivering the courses in India. So just wanted to know how many of you have been to the United Kingdom before? All right, and how many of you have been to Birmingham? Great, you have some. So there is Birmingham, right in the middle of UK. It's very, very central. The region is known as West Midlands. But it's very, very well connected from London. It has an international airport of its own. London is only 80 minutes away by train. It has a very, very young population and a very diverse population, with about 30% of the population from ethnic minorities and 44% under 30 years. And people who live in Birmingham, they want to stay on. So 44 or more than 40% of the graduates from the university who complete their graduation tend to stay on in Birmingham. The city again is a blend of modernity and history. So you'll see here houses with Tudor architecture styles. Birmingham has a network of canals, and I don't know if you're aware of this, but Birmingham has more canals than the city of Venice. And it uses the canal mode of transportation for moving goods, for moving people, than Venice. Now coming back to the university. So the university is truly a global university, and we say that because out of the total 30,000 students that we have, more than 6,000 students come from over 150 countries. And it's not only the students, but also the academics or the researchers, where more than 30% of academics or researchers are from overseas. It's a very, very old university. It was established in the year 1900, so we are more than 100 years old. And we are a part of the Russell Group. Russell Group, again, is a group of prestigious UK universities. It's like the US has the Ivy League, the UK has the Russell Group. So Russell Group University would mean that it would have extra funding, that it would dedicate towards its research, towards new teaching practices, and it's really a matter of prestige that, so when students from Birmingham pass out, what it says is that a certificate or a degree from University of Birmingham would really stand out in their career and their resume. We have recently received a gold rating from the Teaching Excellence Framework. We are consistently ranked in the World Top 100 as per QS rankings, and in the UK we are ranked as 13th. The university is very, very research intensive. It is home to a lot of new innovations and discoveries from pacemaker to structure of DNA to vitamin C and a whole lot of other things. And we're really honored that 11 of our faculty and alumni have been awarded with the prestigious Nobel Prize. And out of the 11 Nobel Prizes, 5 are in the area of health and medicine, so life sciences and medicine. Some of the list that is there is mentioned there. Professor Agarwal talked about, when she was introducing me, about the India Institute. Now, what is this India Institute? So this India Institute is a virtual think tank. It was set up in the year January 2018, and it was done basically to celebrate and showcase the engagement that the university has with India and in India. So, it acts as a like of supportive network for academics, for researchers, for government people, for corporates to come together and, all those who are interested in building transnational educational ties with Birmingham. What do? We offer fellowships. So, Professor Agarwal will be just going to Birmingham in the next couple of weeks and spending some time there. I think Professor Agarwal and Dr. Kumar is putting together a research bid, and the India Institute is supporting for that. But apart from that, our main activities include academic research and scholarship, public engagement in culture, partnership with corporates, postgraduate studies and research. Again, we have a very, very green and open campus. Our campus is rated as the top 3 in the UK, very, very closely located with the train station. With the city centre. The university has its own train station. So if you are to reach, if you reach Birmingham, the main station is New Street, and from there it's only a 7 minutes ride, and the name of the train station is University. We are again very, very, over the last 5 years there has been a lot of investments into the campus, and we have found out that every week there is an investment of £1 million to develop the campus. And some of the examples that I show you here is the green heart that you see here, which is a space, a massive open space that has recently been created where people can sit and discuss things cross-disciplinary. This is the new library facility, which is open 24/7, and state of the art, has the latest collections. And again, below 2 images are again some of the features of the new developments. I would now like to play a very, very small video that will show you as to what is happening in the campus, and I hope we'll have some.
Sound items?
What is on the coat of arms?
I'm sorry?
What is on the coat of arms? One lion, what is the other? Dragon.
I'm sorry to get
The emblem. What does the emblem show?
Yeah, it will come. It's there in the presentation. Just a minute. I'm just trying to sort the sound out.
First one is a lion.
What's your question?
The second thing in your emblem, what does that represent?
Oh, it's just a symbol that the university
You must have done a lot of.
I'm sure there is some history behind that, but I'm not aware of that.
This is a lion, which is very similar.
But the university motto is per the word.
demonstrating ambition.
Yeah, and so I hope some of you will have the opportunity to go and be brave enough to stand below the clock tower while it is chiming and still pass your degree. And the clock tower that you were seeing there, that was the world's largest freestanding clock tower in the world. It is named after our first chancellor, Joseph Chamberlain, and we call that tower as the Old Joe. So that was about the university, and now this is about the College of the Medical and the Dental Sciences. This is, we are very, very proud to have this college. It's a major international center for research and education in medicine, medical sciences, nursing, pharmacy, and dentistry. We develop and promote excellence in basic and clinical sciences, but the ultimate goal is to improve human health and affect millions of lives for the better. Again, this is a picture of the campus, and what I would like to demonstrate here is, if I can have this, so this is the medical school, and see how closely it is linked to the Queen Elizabeth Hospital. The Queen Elizabeth Hospital has the largest critical care unit in Europe, and the college works in very, very close terms with the hospital, providing academic inputs where our students get to go and serve at the hospital. So we work very, very closely and form a partnership. It has got excellent facilities from 24/7 library centers to Institute of Biomedical Research, the clinical research facilities, and the Human Biomaterials Research Center, which has the human tissue banks, the cell therapies, and the gene therapy pharmacies. I mentioned that there's a huge emphasis given on research. Now, research in the college, there are these various institutes that are set up that conduct the research. Dr. Kumar if you can look, is from the Institute of Clinical Sciences, that she's coming and doing research on behavioral medicine. The other institutes that we have are, the ones that I mentioned on the list. We have over 1,000 researchers, and every year we receive more than 80 million pounds of new research funding. So you can imagine the emphasis and the intensive research work that goes in the college. And as a result of which we are credited with certain discoveries. So, the Institute of Cancer and Genomic Sciences was responsible for the vaccine for Epstein-Barr virus, which is associated with cancer. We have been working on reducing the rejection of liver transplants. We have tried progesterone to prevent miscarriages, and we have been working in the area to combat antimicrobial resistance. Now, the Institute of Clinical Sciences, which Dr. Kumar belongs to, is researching on these three areas: advancing nursing science. The two focus areas are end-of-life care. So, ma'am, you mentioned about disclosing bad news, and to cancer patients, there's a lot of research happening on palliative care, end-of-life care, and then the second group is on risk, abuse, and violence. The clinical and experimental oral science and the regenerative and rehabilitative science is for the dentistry, and the drug discovery, delivery, and usage is for the pharmacy group. Now, from among the 5 colleges, these are the various schools. School of Nursing, Dentistry, Pharmacy, Medicine, and Biomedical Sciences, and we offer courses right from pre-registration up to PhD levels. So there's a wide variety, and across all levels you can come and find some options if you're interested. And just to link on to that, this is the list of the 25 postgraduate programs that a medical school offers. And look at the varieties. There are courses from public health, health economics, to clinical neuropsychiatry, genomic medicine, on clinical oncology, clinical trials, trauma science, and a host of other options. And these are not only one-year MSc programs, but you have options for diploma or certificates as well. I think this is our list of useful contacts. If you are on Twitter or Facebook, please follow us, and you will find, you will get updates to all the new research activities or all the new information that we are doing. And with this, I would come to my presentation. I would seriously hope that some of you will have the opportunity and the time to go and spend some time in the campus in Birmingham and experience it live firsthand. But after this, Dr. Kumar is going to come up and she's going to share some of the options that we have thought about for delivering for extending the session that she just delivered today.
So there was a whole lot. I hope you firstly enjoyed the campus. How did you like that? Was it nice? Yeah? It's nice. It's very nice and quiet. Like Sanjay Gandhi is actually a nice campus, but it's full of patients and postgraduate students. And ours is obviously a broad mixture of undergraduate and postgraduates, which is a lovely assignment to be seen. So when we talk about advanced practice, what do we talk about in the UK? So in the UK model is this. So if, example, if me or yourself, you're talking about advancing further knowledge because you are into your administration role now, and what do we kind of think about? So you might then think about looking at a particular model of sort of economy or public health. But if you was in the UK, you would probably, so you're at that point and you're very much on about management and becoming the role of director and so forth and so forth. You would actually go through either doing some standalones, or you would look at doing a full MSc program, or even a PhD, depending on to what level you want to get at. And that adds to your profile and your promotion within that career ladder that you're desiring to. If you was on this side, you think, okay, actually, I've managed to get to this, but I just want to now do I just want to become the director of medicine, but not as a whole of the hospital. So you become director of one speciality. You might want to just do a module, and then there are standalone modules that you want to do, and that then adds value to you promoting yourself in that career ladder. So it depends on where you want to go. So if I could just give an example, like we had one of the rheumatologists, Dr. Sutanaika, who gave up his practice and then became a leader and a director of medicine, and he did his full MSc. Yeah? So it depends on what direction you want to go to. That's the UK model. Now we totally appreciate that here, because of your role, because the structure that you're in, this is very defined, isn't it, for you, which is your DEM and MD and then so forth and so forth. And in between, there might be little choice to engage with anything else. But it all sort of depends on where you are in your career, what you want to achieve. But one thing is for sure, yes, you have a structure of this DM and MD and you're doing, but if you wanted to integrate something else in there, a 1-week program or something, to get a certificate of University of Birmingham, it's a prestige for you, isn't it? Yeah? And that all depends on where you're sitting with your autonomy, where are you with your knowledge, skills and confidence, recognition and the independence. And that, of course, we are ourselves, we're working for a salary. So it all depends. And we just thought, we have been just exploring the whole week, and we are very open for discussion. We are very open for where it fits in for you as an individual. And our colleague over here is looking at painting a picture. Perhaps I could do something on economy or on economics rather, or on public health. So you have an idea in your mind. Okay. So option one is this. Option one is this, that we have we can offer to you 1 week delivery, which is a certificate, which is without any assessment. And this will be 1 week delivered here at Sanjay Gandhi or via online material, online engagement through your wonderful technology here. And here, these are just some proposals of topics that, because Dipankar has doing his homework before my visit to centres, these are the kind of things that people want, effective communication and the session that I've just presented, looking at clinical pathways and how would you might want to make them work, and then evaluating them, leadership styles, leadership skills, and anything else that you might want to add to that. So that's 1 week as we're proposing. Week 2 is a postgraduate certificate that accompanies with some credits. And as you know, credits are very, very important. Credits, and this is if you are looking to do further masters of any type. So you might want to then say, okay, I'll take this option, and it gives me 60 credits. It's with assessment, and this might be, what does this look like? It might be a 3-week delivery here on home ground. This is not 3 weeks all in consecutively, but this is perhaps 1 a month, because we know that your time constraints and you can't take out 3 weeks from your clinical practice, so this might be 1 a month that we might be able to. And these are the kind of topics, again, these are just suggestive, and if later on when we're having a discussion with Professor Agrawal, you think, okay, let's look at that proposal, but with this in there, then we can make that happen. But these are just examples of the things that we can offer to you.
And just to mention that 3 weeks here can again be a blend of 1 week face-to-face and the rest 2 weeks online, so that you don't have to, you have the convenience of doing it at your convenience. You don't have to take out time when you're seeing patients, and you can distribute your workload and complete them.
Yeah, because we're learning that actually that's not a massive option for people here. So the other one is, option 3 is a diploma or an MSc full. This will be, again, a blended learning, some contact face-to-face where we come out and we spend some time with you. A majority of the material being online. So if you wanted to look at the diploma, if you just follow this green grid here, these are the topics, and I already presented some of them earlier to you, just borrowed from this program. Applying and creating and applying evidence is very, very important, as we talked about it. This is very important in research. It's about how do you create it and how do you apply it and how do you write up for publication. Leadership is also important, particularly if you're leadership within your own field, in your own clinical role, but also at a wider leadership. Perhaps for some of you this might not be so much, we can replace that with something else, but clinical health assessment might be important for nurses, for example, who want to advance their skills, who want to advance their knowledge. And perhaps if you started to make the start of looking at such a module, then perhaps people like Amita Agrawal, then actually endorse to say that they can add value to the workforce. You can share that burden that the clinicians have all year long. Semester 2 is looking at research methods, and I think Mita was talking about this earlier, cross-sectional large, how do you set up studies, and she's already doing some workshops around that. But that's a module built in with this diploma. Transforming healthcare design, again, it's about looking at what you're providing and not becoming in the conveyor belt. And this is where I think that the vision is to break that cycle of that conveyor belt, is doing things more innovatively, more effectively, efficiently, with good clinical outcomes that allow you to publish. And there is this current issues in healthcare. Again, it looks at issues, and here in this country you are fully aware of them, but how do you then draw up plans around those challenges more constructively? And each single one of these modules have an assignment. So that is the diploma, and that gives you 120 credits. Then if you wanted to do the full masters, then obviously there is the dissertation at the end. Okay. Option 4 is exactly the same. The only difference in this option is that you come to the UK for 1 year, and I know before you run out of the room, that's not possible for this audience.
actually it's not possible for any of the audience that we have spoken to over the last week. So, but we thought we'd just offer it to you. It might not be like for, sorry, what's your name? Saurav. So for Saurav, it may be that he has the capacity to study a full MSc, but in economics or in public health. So that's fine. So yesterday we were at the SGT, and there was a dentist who wanted to come out and do a full master's. Orthodontist. So it depends in what you require and what your requirements are. We just thought that if we can just present some examples to you rather than giving you a rigid program that we have in the UK, which is only suitable for UK audience, then we know that that was a benefit for you. So these are the options. So I just like to open the session for questions now, Nita. Yes. Yeah, if anybody's got any. Any questions, guys?
So what options do you have for nurses? Because our major issue is that our institutions don't empower nurses to do anything with the patients, like this kind of patient education and all. So what can we do for that?
So, if we just go to big one.
Yeah, I think option one.
Option one. So this was actually also raised by CMC. And they said that, we want to power up and really recognize the force that is underdeveloped. And Anita is a real ambassador as well for Sanjay Gandhi. So for your girls, or for your staff rather, sorry if there's any boys in that category.
There are boys also.
This could be a real winner for you guys. And we're going to have a chat later on about a suitable, manageable price that can be, fitted within your timetable. But I would suggest that this is the kind of thing that allows you to go into a role, and of course, then you will work with, your professors and your senior people to further develop. Who are the nurses in this room? Can you put your hands up for me?
Yeah, but half of them are nurses.
Very good. Okay. So you guys might be able to do something like this, and then really develop, and then further maybe with people like this sitting here who are your ambassadors, then you might be able to walk towards CPD, the postgraduate certificate, or even diploma. Who knows? I know what the vision is. But just as a start, this is good. Any other questions? Don't be shy. I'm going back tonight.
You are from hospital administration? Yes, ma'am. So what are you doing? Mitchell.
Any other questions, guys?
Okay. Are you happy?
Yeah. Well, I would just like to say thank you so much for taking out your time, and it is a Sunday. Thank you so much for your attention.
So at the end, I would like to thank Dr. Kanta for coming all the way and really telling us that we really need to engage with patients. We all know that it's just a different way of putting it, because engagement with patients, everybody does it in their own style. It is that if somebody points out that these are the few lacunae we are not looking at, like Pankti does her own way, she has done the way we do. And if we know the lacunae, we can improve. So there is always a scope for improvement. So that is what we are looking at, that if we can do, because in tertiary care hospitals, we are managing patients with chronic disease. We are rarely managing patients with acute diseases. So chronic disease care is a very different type of thing, which means that the patient is engaged with you, and you have to be actually like a friend with the patient, rather than be on a pedestal that you are higher and the patient is lower. So I find that if you are at the same level, you are able to communicate better. The second, if you use the patient's language, if a Sardar comes to your office and if you speak in Punjabi, the first sentence, when all the barriers are broken, your connect is instant. And if you can speak in multiple languages, it gives you a really advantage in India. And the third is that you have to talk at their level. Whatever is their education level, unless you come down to that level, you are not having effective communication. You think you are communicating, but actually you're not communicating. And the fourth in our country is that we don't need to be judgmental. Whatever the patient can afford, we should try to provide best possible care in that much of money. We cannot keep telling a person who's earning 10,000 rupees about biologics, which cost about 30,000 a month. It is absolutely insensitive, I feel. That if we shouldn't even talk to that patient about those therapies and make that patient feel miserable that there is some therapy which I cannot afford. Even if the patient doesn't need it, you don't need to talk. So we need to be very, very open and understanding of the patient's situation before we start talking to the patient. And that comes with time. We have also learned over time. I have now become old, so probably I have much more knowledge on how to go about with each different patient. When we are young, we don't have that much of information and we don't know. And we are always in a hurry. Younger people are in more hurry because they probably have 10 more works to do. We are more relaxed. We feel it doesn't matter if we are sitting till 7 p.m. also, it is okay. We don't have so much work at home. Probably we can spend more time. So it changes with time, but that is why we wanted to have Bhanka, just to give you that this is one area which we are lacking. And all of us can think our own ways and do. Probably I feel some of it doesn't even need teaching, but teaching gives you a thought that there are many different ways to do a thing and different ways can suit different patients. So thanks a lot again, and Dipankar, thanks for you coming all the way from Delhi. And we hope to see you again sometime. And I will thank all of you for coming on a Sunday and spending time, which is very difficult because we rarely get holidays, and especially for fellows. So please join us for a simple lunch and then we break. Thank you. Thanks a lot.